Put it onto presenter views. Could you just change the top so it looks as presenter views? There we go. It's okay. Beautiful. Sorry, take 2 seconds just to get this all in order. Well, thank you very much for having me come to India and talk. It's been a real pleasure, and it's amazing the quality of the conference and the amount of interesting stuff that's been presented. And thanks particularly to Michael for that quick rundown of such a large topic. Well, I hope my talk today is half as good as the singing I heard last night. I was totally amazed at the Indian karaoke skills. They certainly don't exist in Australia. We might have beautiful sun and a lot of good beaches, but we certainly don't have good voices. So that was a pleasure last night. As a registrar, I developed the technology that's now used on the Sonoplex range of needles. That was my foray into regional anaesthesia. So obviously I'm heavily conflicted on the topic of regional anaesthesia, as I'm keen for us all to do as many blocks as possible, but I hope I'm with good company in the crowd here. Developing great ultrasound-guided regional anaesthesia skills is really important because it's like your toolkit. It's the tools you take to do every single block. If you're good at your needling skills, every block is probably going to be a lot easier. And if you teach your registrars these skills, their pathway to being good regional anaesthetists is going to be a lot quicker and easier. My feeling is really there's been a lack of attention given to just ergonomics and needling skills, and I think that's a shame, and hopefully this will be the start of the process of people working on a little bit more. Just so you know, I have actually printed a handout of my talk, so instead of you needing to write any notes or anything for the day, I think they're going to be available just at the back as you leave today. If not, if you go to the Hospi Medica Payunk stand in the Trades Hall, they've got copies there as well. So ultrasound guided regional anaesthesia is it a thinking game or a sport? I think it's a sport. Certainly it's a lot more like a sport. It's a technical skill, you can practice it, you can discuss it, you can improve it, and it's fun. But it's much more like cricket. And what it needs is some good technique taught to you. And I think if you look at cricket, most of our cricketers end up playing cricket nearly identically. Do you know the great batsmen don't have all vastly different styles of how they bat? They stand and hit their classic shots in very similar ways. I'm just going to now show you a nice little video. I hope the volume and everything.
So Ricky, what can you tell me about batting?
Well Jack, we'll start with the absolute basics, and the first one of those is the grip. So what I want you to do is lay your bat flat on the ground with the handle facing towards you.
Yep.
Make 2 nice V's with your hands. Reach over and pick the bat up.
Yep.
Okay. Next thing is to spread your hands out nice and evenly on the handle.
Yep.
And then we get straight into facing up. The second part of that is the stance, which is very, very important.
Yep.
Okay. We want to have our feet about shoulder width apart.
Yep.
Okay. But most importantly, when we're facing the bowler, we want to have our head and our eyes facing straight towards where the ball's coming from.
Yep.
Okay. And have our eyes nice and level. So we look down, we look up, get our eyes nice and level, and wait for the bowler to come in and bowl.
Cool.
Now, cricket's got a bit of advantage. It's come from the 16th century, and we've had a lot of years to learn what's good and right with cricket. Where ultrasound-guided regional anaesthesia, it's really only about 15 years old. So I don't think we've really developed that technique yet of teaching. But I think this is the idea of what we should be aiming towards, so that our registrars are getting taught optimal skills from the start. Sorry. I just thought I'd throw this in while I was going past. Isn't it lovely? Australia, India, top of the table of the World Cup. I'm praying that it will be an Australian-Indian final, and you probably know who I want to win, but I know you're on the other side. Anyway. So when I look at the published literature that's out there about ergonomics and needling skills, at the moment I have to admit I'm pretty disappointed and that I think it really isn't up to scratch. And a lot of what I see in the educational sites I actually find a bit bizarre. This is just one example, and I feel bad that I'm picking on the block guru because it's their image, but I've got some from all of them, so I'll show you a few in a minute. But I'll show you that I'll probably use the pointer over onto this centre screen. This is the problem with this block. There's lots of problems with this block. Firstly, the hands are way off to one side, so that it's quite an unnatural position to be trying to do the block. The area where the doctor is inserting the needle, he can't even see because his ultrasound probe is in the way of his line of view. So to be able to drop his eyes down to see if his needle is in line or not. Okay. Oh, okay, that's okay. I'll just... you know, the pillow's all in the way so that, you know, our sterile needle could easily brush past the pillow because he's not actually able to see it while he's doing it because it's hidden by the hand. The next line down the bottom I find even more bizarre. You know, he's doing a right-handed block up here with the needle in the right hand. If you look down here now, he's got the needle in his left hand. Now, if you sent your child off to cricket to get trained by the local coach, and half the time they was teaching him about right-handed and half the time he was teaching him about left-handed, I think we'd all go, that's not right. So if it's not good enough for cricket, why is it good enough for medicine? You know, let's get people using the optimal skills, which is keeping the needle in your dominant hand. I said I'd have a few shots at everyone else's promotional stuff as well, so the top one's from AORA. Once again, the ergonomics of this are probably going to be bizarre. I'm not sure where the ultrasound machine is actually going to be sitting. This AORA video is another left-handed block. The block jocks from America, once again, another left-handed block. Bad ergonomics on the hands. So now what I'd like to do is give you my opinion. And some of it's got a bit of science and research behind it, and a lot of the other stuff's just what I think is common sense. And from my experience of teaching registrars over the last 10 years. The first thing I'd like to point out about this image, because I think this is really good ergonomics for an interscalene nerve block, is that everything is in plane. From the eyes down through the probe to the ultrasound machine is all in plane, and you can see where the needle's being inserted. There is actually a little bit of scientific evidence to back up some of this. There's a nice study that's being done where you can have the operator sitting directly opposite the monitor with the phantom in between, or the block in between, or at right angles. And this study clearly showed that it's more effective to be doing the block with everything lined up. The second lot of research looks at whether you do the block across the visual plane. So your visual plane's from from your eyes over to the ultrasound machine, whether it's more efficient to do the block across the visual plane or along the visual plane. Once again, this clearly demonstrated that it's more efficient to do your blocking, along the visual plane. Which brings us back to this image, that you should have everything lined up and you're along the visual plane. So of a sport, it's also a bit more like throwing a dart at the darts board. I don't know if darts is very big in India, certainly big in the UK. And I know that if you went to a pub in the UK and somebody, after a few drinks of beer, started wanting to throw their dart across their visual plane like this at the dartboard, you know, the crowd would be moving well away from the dartboard. And the efficient way to throw a dart is from your eye to the dartboard, as displayed here. Just a bit of terminology just to make it doubly clear what I'm talking about. We talk about in plane as that sort of 2D area underneath the ultrasound probe. What I'd like to have you do is broaden your thought of that and really think that in plane is that whole two-dimensional space around your ultrasound probe. And so if we're following what those two studies have shown, we should have our eye in plane, our needle tip and the whole needle in plane, and the ultrasound machine in plane. Hopefully not with a heart in it. So just going back to this image one more time, what I've described so far there's some scientific evidence for. Now what I'm going to describe is some of the things that I think are good techniques to add to that. The firstly is what the height of the bed is. If the surgeon asks us to raise the bed, we don't say, oh, how high do you want it? We normally just take the bed up to the height where the elbows are about at right angle, because that's a really comfortable place to do any work. So once again, that's the height that we should have the bed when we're doing our blocks. The second thing is you can notice here that the patient isn't lying dead flat, that we've lifted up the end of the bed. What this has done is meant instead of having the probe on an angle, as the bed's lifted, the probe is now gone to nearly a straight vertical position. Once again, it just makes the needling easier because everything's obvious in front of you. Another small subtlety is the shoulders. A lot of people stand straight on when they're doing a block, and this immediately causes a problem because to fit your needling hand behind your probe hand, everything's squashed. This problem's fully resolved just by moving your shoulders about 30 degrees or 45 degrees around, and then your needling hand is now naturally sitting behind your probe hand. Easy little change. Last one I want to just talk about is what's going on with the hands. What's crucial is that you hold the probe really low and that you've got a large amount of your hand on the patient. You spend a lot of time scanning before you start needling, trying to get that optimal, perfect view of the nerves. What you want to do is make sure that that's then held exactly still while you're doing the block. You can only achieve that if you've got a lot of grip of the patient. My concept with all of this is the body wants to stay in the most relaxed position while you're doing the block. If you start in a nice, relaxed, comfortable position, you're unlikely to move. If you start in some contorted position, as soon as your brain's thinking of the block and everything else what's going on, what the body does, it just naturally unfolds and starts moving towards a position of comfort. It only has to move a few millimetres and you've lost your perfect view or you lost your view of the needle. But if you start off in a position of perfect comfort, you don't move. The other important part of this image is that you can always have a really good visualisation of where you're inserting your needle. It shouldn't be hidden by the probe or around a corner. Where you're inserting your needle is directly in view. So basically, every single block we can do, it's easy to get the ergonomics so that the patient's correctly, it's easy to position the patient so that we've got good ergonomics. Here's a femoral nerve block. It's classically been considered the easiest ultrasound-guided regional anaesthesia block. I think the reason for that isn't that it's an easy block at all. The reason is it was the first one that everyone could set up the ergonomics easily for. Actually, I find this block probably one of the hardest blocks, because you often can't really see the nerve until you get your local in between the muscle and the nerve to display the nerve. So it can be quite hard. Just show a few other blocks as well, how you can do it. Popliteal sciatic. A lot of people try and do this block with having somebody raise the leg and put the probe underneath and then needle everything upside down. It's hard for your assistant because they're holding the leg. It's hard for you because you feel hurried, and it's also hard to hold the probe. If you turn the patient, just roll them on their side, put them like this. You've got a lovely view of where your needle's going. Everything's much more correctly orientated on the screen, and it's comfortable for both you and the patient. Last one is just the axillary nerve block. This is a way of just setting that up so it's all ergonomic for you. Now, I know that there's going to be some people here in the crowd lots of people here in the crowd who are all already awesome at their ultrasound guided regional anaesthesia, and I'm sure they don't follow a single tip that I've just talked about. They've learnt their own techniques and they're now really highly efficient and really good regional anaesthetists, and that's fine. What I'd suggest to you though is when you're teaching, you think about how you're going to teach someone, because if you teach somebody your skills and your technique, it might take them a very long time to learn. Where if you can set people up with nice ergonomics from the beginning, you'll find that their learning pathways a lot quicker. And if we're wanting to turn regional anaesthesia as from a small group to actually everyone being able to do it, ergonomics is a key bit to that. The second thing I just want to talk about is a simple needling technique. And of any part of my talk, this is only going to take a few minutes. This is probably the best of it. I'm just going to run through what I do as a needling system, and this is what I talk through with the registrars every time they do a block. Let's pretend we're doing an infraclavicular nerve block. What's happened here is you've spent quite a bit of time scanning to get the perfect image of your nerves. At that stage, what I do is I encourage the registrar that they've got the perfect view, they've got a nice low grip on the probe and they're holding the probe perfectly still, that they have a look at their block and they predetermined how far the needle can travel before it gets to the nerve. So here, the needle's going to come from somewhere into the outside here, and we're wanting to get down to the nerves here. It's a 2.5 centimetre wide probe, 4 centimetres is down here, so let's call that 2.5 centimetres. So it's probably 3.5 centimetres the needle is going to move to get to the nerves. So what that means is it's perfectly safe to put the first 2 centimetres of the needle in without watching the ultrasound. You predetermine your distance that you're going to insert the needle, and you predetermine what direction you want to put the needle in. In this case, it's going to be about 45 degrees. At that stage, you stop looking at the ultrasound machine. And if I've got the registrars with me, I now put a piece of paper over the ultrasound machine so they can't look back at the ultrasound machine. What they've got to do is look at their needle insertion. And sorry that I'm just using phantoms for this, but what you want to do is make sure you get the tip of the needle exactly in line with the edge of the middle of the probe. That part's easy. Most people do that already. But what happens for most people at that stage, the moment the needle is through the skin, they go back to looking at the ultrasound machine. And then they start advancing the needle, wondering when they're going to see the needle. So the biggest change is don't look at the ultrasound machine at that stage. Insert the needle that predetermined distance that you know is safe while you're looking at your needle. And then before you look at the ultrasound machine, you do 2 things. You go, am I perfectly in plane? Is my needle sitting perfectly in line with the ultrasound plane? And have I inserted at the correct distance? If you do those 2 things, about 50% of the time when you look up at the screen, you're going to have your needle sitting there. Now, you only have to be wrong by a millimetre or 2 and you won't see it. So if you don't see it, it's not a big issue. All you need to do is a very small translocation of the needle to find the needle. I use those words carefully. So if you haven't seen your needle at this stage, what's going on is your needle is sitting, most likely you'll have it in plane, but it's just off plane. Sorry, it's parallel with the in plane, but it's just off to the side. The movement to find your needle is translocation of the probe. You move the probe left and right to bring the needle in plane. What a lot of people do is that when their needle's not in view, they tilt the probe to find the needle. And it's very effective. Tilting the probe will bring the part of the needle into view, but it hasn't moved the probe's relationship to the base, at the relationship between the needle and the base of the probe. So what happens if you tilt the probe to find it like this? You end up with a rotational error, and so you've still got more correction to do before you can continue moving your needle. And if you've got a rotational error, this might be the type image you get where you've got a bit of needle in the screen, but there's a lot of needle that you can't see. So if you look and you can't see your needle, and you do a small translocation left and right, and you can't find your needle at that stage, there's only two possibilities. And both of those possibilities are solved by dropping your eyes back down to your probe. The only two possibilities are where you actually move the probe by a lot while you are moving your eyes from looking at the needle to up to the ultrasound machine. That's easy, just move the probe back over the needle. Or you haven't actually inserted the needle as far as you thought you had. So with needling, key things to think about: get your ergonomics in your room set up correctly at the start. Always confirm the orientation of your probe. We haven't gone over that, but make sure you hold the probe low so that you're resting on the patient so it doesn't move. On insertion, make sure that everything's in plane and that you're going to insert your needle a predetermined distance and a predetermined angle. If you've got poor needle visualisation, stop moving your needle and move the probe to find it. And once you have got good needle visualisation, then you just hold your probe nice and still, don't move it at all, and now you're moving your needle. As I mentioned, all of this is going to be on the handout you can pick up. I hope that has been of value to you all, and more importantly, I hope you can take on some of that knowledge to teach your registrars. Thank you very much for your time.